focused on overview of pituitary syndromes and hypopituitarism. And the objectives of today's lecture would be to give you a brief overview, because this is an overview, so a brief points all about what the pituitary tumors are, how are they classified, and what is the epidemiology. And then we'll talk a little detail about acromegaly features, investigations, and its management, and I'll briefly touch them all. And similarly, Cushing's disease, features, investigations, and management. And finally, we'll talk about hypopituitarism and how it is classified, what are the various causes, what are the clinical features. I may not be able to go into the detail of how we manage hypopituitarism because of the interest of short of time, but obviously the hormonal deficiencies which are expected in hypopituitarism have to be addressed. So I hope you all know about anterior pituitary, basic cellular anatomy, that is the cell types. The acidophils, they are somatotrophs and lactotrophs. So somatotrophs are supposed to make growth hormone and lactotrophs are supposed to make prolactin. Similarly, there are basophilic cells which are divided into corticotrophs, thyrotrophs, and gonadotrophs. And the corticotrophs are supposed to make, this is POMC, or you can say pro-opiomelanocortin, and then ACTH is adrenocorticotropic hormone. This is a melanin stimulating hormone, endorphins, and lipotropin. These are all secreted by the corticotroph cells. Then thyrotrophs, they secrete thyroid stimulating hormone. Gonadotrophs secrete follicle stimulating hormone and luteinizing hormone. Now, what are the pituitary tumors? Pituitary tumors, they are common neoplasms, and recognition of their presentation is critical since a favorable therapeutic outcome is dependent on the early identification of the lesion. So this is just to understand that although they are neoplasms, but they are not considered as, brain tumors, as cancers or something like that. Because as I said, that when they are recognized earlier, they can be treated to the extent that they can be cured easily. So the pituitary tumors, they represent anywhere between 10 to 15% of all intracranial tumors. So this is quite a big figure actually. And incidental tumors can be found in approximately 10% of autopsies. And coming to talking about incidental tumors, when patients go for imaging, from brain imaging for some other purposes, for example, if a patient has suffered a cerebrovascular accident or stroke, and there can be an incidental finding of a pituitary tumor. So even in living persons, you can still have incidental finding, and we call them incidentalomas. Mortality rate related to pituitary tumors is very low. As I said, and I have explained earlier, that early detection, early identification actually leads to cure. So it's low. Advances in medical and surgical management of these lesions and the availability of hormonal replacement therapies have contributed to successful management. Now, how do we classify pituitary tumors? Broadly, they are classified based on their size into microadenoma and macroadenoma. They can also be classified based on their cellular type, like, for example, chromophobic and chromophilic. So chromophilic are the ones which take the stain, and chromophobic are the ones which do not take the stain. And when you look on them on histopathology, you may not be able to identify which type of cells they are. The endocrine morbidity that is associated with pituitary tumors depends upon the specific underproduction or overproduction of the hormone or hormones associated with a tumor. So a tumor can be non-functioning, and it leads to suppression of the surrounding normal cells, leading to underproduction of the hormones. It can be a single hormone, and it can be all hormones in the pituitary. Similarly, overproduction is by a particular type of cell, as I've explained earlier in the table, the types of cells. So two types of cells can be overproducing at the same time. For example, it's very common to see growth hormone as well as prolactin secreting tumor, which are coexisting. So as I told you, there can be a non-functioning tumor. They are called non-functioning pituitary adenomas. They consist of 10% of all intracranial neoplasms. So if you ask me what are the most common type of pituitary tumors, the answer is non-functioning pituitary tumors, non-functioning pituitary adenomas. They are the ones which are most common. and 25 to 35% of them are actually non-functioning. Why do we say that? Because most of them, they arise from actually gonadotrophin cells, and they are monoclonal in origin. And being coming from the gonadotroph cells, they do not manifest so much in the a hypergonadotrophic type of syndrome, which does not really exist. But if you check the hormonal levels, you may find FSH and LH which may be raised, or sometimes they do arise from gonadotrophin cells, but they are not producing these hormones, that is the FSH and LH, although they are monoclonal in origin and they are non-functioning. And most of them are macroadenoma. Why so? Because in the initial stage, when they are in the microadenoma state, that is less than 1 centimeter, they are not causing any functional manifestation to account for any hormonal syndromes, and then they are also not accounting for any space occupying lesion causing pressure effects in the brain. As a result, until unless they grow in size to achieve a macroadenoma size, they do not come into clinical attention, unfortunately. So usually discovered because of the space occupying effects or inadvertently. Now let's start with acromegaly. A general presentation in adults is changes in the size of the hand, feet, coarseness of the face, frontal bossing, prognathism. And in children and adolescents, may result in pituitary gigantism. So there will be a tall stature because of the because of the excessive growth of the growth plates of the long bones. Acromegaly frequently results in a glucose intolerance, with 20% of patients progressing to diabetes mellitus. And then patient can also experience respiratory difficulty and sleep apnea because of the soft tissue swelling and growth inside their inside the pharynx, inside the larynx. So there can be cardiac complications resulting from acromegaly cardiomyopathy. Patients may have a bulky appearance. Generally, they are weak as a result of associated myopathy. There can be carpal tunnel syndrome because of excessive soft tissue around the median nerve in the wrist joint. Then there can be lumbar canal stenosis, which can present with a syndrome resembling amyotrophic lateral sclerosis. So amyotrophic lateral sclerosis, the condition, is a type of a motor neuron disease where motor tracts in the spinal cord, they degenerate due to genetic and hereditary problems. Same happens when the lumbar canal stenosis happens in for example, in acromegaly. So patient can have weakness of the limbs, especially lower limbs. And then acromegaly may be associated with colonic polyps with an increased colonic cancer incidence. So when you come to the management, for advanced managements, then you have to screen these patients initially 5 years time, after every 5 years for the presence of any polyps, and if so, then you have to biopsy them and see if they have any malignant potential or cancer potential, so that you can take a preventive attempt and go for preventive treatments. Sorry, I missed a slide, I guess. Okay. So the incidence of acromegaly is approximately 4 per million, which is almost the same worldwide. And it has no sex predilection. Male, female can equally be affected, usually present in 4th or 5th decade of life. So if you consider this, then usually women would present with, in the reproductive lifespan. Males can also come and complain several things. So clinical features, as I said, a multitude of clinical signs can be appreciated by comparing the current facial appearance with prior photographs. So whenever you expect or suspect a patient to have acromegaly, ask them to show you, past pictures, which may be a 6 month or a year or so back, and then you can compare those pictures and understand if there had been a classic change in the course in their facial appearances. Patient can have large hands and feet with thick fingers and toes, coarse facial features with frontal bossing because of enlargement of the frontal sinuses. And women may appear masculinized. There can be prognathism. What is prognathism? Prognathism is basically, is enlargement, or, you can say protuberance of the mandibular jaw beyond the maxillary jaw, or vice versa. It can be either way. So that has to be judged from the side profile of the patient when you clinically examine them. And then other features, as I said, there can be carpal tunnel syndrome, change in voice quality. So this is an example of pituitary gigantism. Okay, this is a normal statured, or you can say or an average statured person, and this is a guy who has achieved a quite tall stature because of the pituitary gigantism, and it has to occur before puberty strikes, because after puberty, the growth potential change due to the presence of sex hormones, and before that, if the growth potential is exaggerated, as in case of acromegaly, or if the puberty is delayed and does not occur on time, then the height, the stature of the person can continue to grow exponentially. Okay. Again, these are the examples of coarse facial features. You can see there are broadened nose, there are frontal bossings. You can see that, and I mean, if you see the side profile, then there is a little prognathism of the lower jaw, and again there is frontal bossing, very obvious here. These are the example of enlargement of or spade-like hands. This has been compared with an ordinary or an average statured, average normal person hand, and you can see they are quite coarse in features. They are broad, and if you touch them, they are soft, fluffy, and have hard to rough skin. So how do you work up these patients? There are two lines to work upon. For one is for hormonal hypersecretion and other pituitary functions, and the other is to see if there are any pituitary mass effect going on inside the brain, inside the cranium. So random growth hormone level can be checked, but it has a day-to-day variability in hand, and it has a diurnal variation. Plus, it releases in pulsatile manner and is affected by the physical setup of the patient. So it becomes unreliable, unfortunately. Although you can still, if you check it after every, if you admit the patient, if you want to see the curve, how it's going on, you can check it, take the sample after every 5 minutes, and then see if there is a rising trend overall. But this is not a very practical test, and it's quite cumbersome to take upon the patients. And usually these are also performed in specialized centers where there are a lot of facilities for the patients. So this is there, but we don't usually do that in our clinical practice. Other test is insulin-like growth factor 1 level, which is more reliable and the first line screening test. And the second one is the oral glucose tolerance test, growth hormone suppression test, oral glucose tolerance growth hormone suppression test, which confirms the finding of acromegaly. And then for mass effect, as I told you, we have to work upon two lines. We have to see the visual fields, which can be assessed clinically and by formal perimetry. And then you have to image the brain for pituitary or Sella lesions. So going on to the explanation, IGF-1 level is the first line test for acromegaly. It reflects the growth hormone secretion in the last 24 hours at least. And technical factors may limit its usefulness in some laboratories as well, but it does come in a smooth way to let you know if it is raised. You can at least suspect that, okay, when I am suspecting this patient clinical features to be due to acromegaly, and if IGF level 1 is raised, then this can be the real acromegaly, and I should proceed further. So when we proceed further, you go for oral glucose tolerance with growth hormone suppression. This is the definitive test for the diagnosis of acromegaly. A positive test result is the failure of growth hormone to suppress to less than 1 microgram per liter 2 hours after ingesting 75 grams of oral glucose. So you might have heard about oral glucose tolerance in case of diagnosis of diabetes mellitus. This is the same test. The only additional procedure to perform is to check the growth hormone level after the 2 hours of ingesting that 75-gram glucose. So let's begin with Cushing's disease. Basically, it is a clinical presentation of excess cortisol in the body. Most common cause is iatrogenic steroid use. Steroids are used for several medical purposes, asthma, COPD, several rheumatic diseases like rheumatoid arthritis. Then there's SLE, and there's several dermatological conditions where you use this steroid and so on. And if, for example, unfortunately, patient has to take large doses for several days, then there is a chance that the patient may develop iatrogenic Cushing disease. Cushing disease is excess cortisol production due to pituitary ACTH secreting microadenoma. So why I specify here that it's a microadenoma? Because it can go on to develop a macroadenoma as well, but the micro comes into attention fairly quickly. Why? Because of excess cortisol production and its clinical manifestation, which I'll discuss later. So untreated Cushing syndrome has a very high mortality. Usually it is a rare disease, annual incidence just 2 per million. So the incidence might be increasing with time, how the population of the world is growing, but it's actually quite rare. So whenever someone tells you, okay, this is an obese person or can be Cushing, so be very suspicious and thoughtful. Okay, it's a rare condition. Let's look into the features carefully and be thoughtful. More common in women, female to male ratio is 3:15:1. So it's quite common in women. Why? Why? Because again, hormonal problems of any kind comes earlier to clinical attention in women because of their reproductive life, because their monthly menstrual cycles getting affected. So they often come to the gynecological and obstetrician practice, or straight to the endocrinologist saying that, oh, my periods are getting disturbed. So there may be some hormonal issues. Then you go into clinical examination, you get to find out, okay, this patient has acromegaly, or this patient has Cushing's or whatsoever. Usually this patient presents in third to fifth decade, so you can understand this is the reproductive lifespan of a person. Clinical features, as I told you, obesity, centripetal fat distribution. So all of the fat distribution comes to the axial or central part of the body. You get a big tummy, and there is a buffalo hump, which is not the term being used now. This is actually a posterior suprascapular fat pad. And then moon faces is the rounding of the face, again because of the fat deposition. Proximal myopathy. There can be cataracts because of high blood sugar levels. There can be arterial hypertension, bruises, skin striae, and these are all because of the excessive cortisol causing disturbances in various processes of the body, normal body mechanism, metabolism. This is a typical picture of a patient with Cushing's disease, and you can see here there's a centripetal distribution. You can see the legs are quite thin, the arms are also thin, but the abdomen is quite swollen, and they are fair, big, large stria. You can easily see them. And then there is a suprascapular fat pad behind the neck, and sometimes there is a fat around the supraclavicular region as well, and patient looks like having a rounded face. Again, this is a closer look. So females can come up with hirsutism, okay, excessive hair on their face, and sometimes acne as well, and there can be acanthosis nigricans, which you can appreciate here, I hope. And these are the large pinkish to purple large stria. For Cushing's stria to be identified as due to cortisol excess. Remember, the clinical criteria is usually that they should be large, they should be pinkish to purple in color, and they should be more than 1 centimeter in width. So it is large and it has a broad width because collagen is being destructed and not adequately reformed because of excess cortisol. So the challenge with Cushing's is not the clinical identification. I hope you can appreciate that. You can easily pick someone coming in your ward or clinical OPDs to say, okay, this may be a Cushing syndrome. This patient has a Cushingoid appearance. The challenge really is to find out if it is really an endogenous glucocorticoid or steroid overproduction, or if it is an iatrogenic one. Then if it is endogenous, then where is the source, which we are going to discuss here. So you can just briefly understand that after you take a careful history, which is very much important, you must identify whether the patient is taking any exogenous steroid use. In our population, patients are used to taking Hakimi and homeopathic medicine, so be very careful, be wary about it. Take a thorough and thoughtful history that if patient has taken, because these steroids are also available over the counter, so patient might have taken some betamethasone or betamethasone or dexamethasone type of tablets to boost them up to fight day-to-day flu, fight day-to-day mild infections. Some local practitioners also try to get rid of their patient troubles by advising them steroids. So be very careful. If the patient take a thorough history, the main theme is to dig out the history really well, and then of course do the careful and detailed clinical examination. So investigations to perform are at least 2 first-line biochemical tests to obtain the diagnosis. Number one is the urine-free cortisol, for which you should take at least 2 measurements. And then there is the second test, which is late-night salivary cortisol. Again, you need a 2 measurement for that. Number 3 is 1 milligram overnight dexamethasone suppression test. Number 4 is the longer low-dose dexamethasone suppression test, that is 2 milligram per day for 48 hours. Once you have a positive diagnosis out of these 4, if you perform any 2 and if you get positive result in them, then you are okay, this is excessive cortisol production, okay, fine, we are dealing with Cushing syndrome. Now you need to localize where is the cortisol coming from. So you should know that cortisol actually is produced by the adrenal gland, but is the problem with adrenal gland or is it getting from the pituitary? Because if ACTH is overproduced, again you will get same Cushing syndrome. So you have to see whether it's a primary adrenal problem or whether it is a primary pituitary problem. For that, you need to perform high-dose dexamethasone suppression test, which confirms pituitary adenoma. It suppresses the pituitary gland even in the presence of an adenoma. And if cortisol level remains high, then pituitary adenoma is not the cause of higher cortisol production. Then you may have to think, okay, it can be an adrenal source or it can be somewhere ectopic source. So I'm not going to go into the detail of the ectopic source, but I should tell you ectopic means something which is not the normal of the normal mechanism, because we expect cortisol to be produced from adrenal and ACTH to be produced from pituitary. But if these 2 hormones are being produced from tissues other than these glands, that means they are from ectopic source. For example, some lung cancers like small cell carcinomas can produce ACTH hormone, and then they can also present with Cushing syndrome. Similarly, this ACTH hormone is usually the source of ectopic hormone, and it can be produced from some of the pancreatic or neuroendocrine tumors in the pancreas or in the gut. So these are such as a bit detail and further advanced, causes and details about Cushing syndrome. But you must understand when the high-dose dexamethasone suppression test is coming out to be not normal, that means that cortisol still remains high. Then you have to think about other options. The second step is to check the serum levels of ACTH. The serum concentration of ACTH is higher than normal, that is more than 4 picomole or 18 microgram, then it suggests ACTH-dependent Cushing disease, and ACTH-dependent Cushing disease can come from pituitary gland. These are the example of how you assess visual fields of a patient. When you do a clinical assessment, it is a confrontation test which you must learn in your clinical rotations, and how to perform a clinical confrontation test for assessing the visual fields. And this is a formal visual assessment by Goldman's perimetry, and there are other types of perimetries like Hoof-Race and so on. But this is an example of Goldman's, where you ask the patient to look at the the black spot on the left side is supposed to be is the normal blind spot here, okay, and on the right there is an abnormal visual field showing that defect that involve both the central and peripheral vision, and visual fields are likely to be noticed by the patient. So these black spots means that patient says, no, I cannot see. And these white ones are the one, okay, patient says, okay, now I can see, now I can see. And you actually show a pointed light to the patient in this test. This blank spot that they are saying is the blind spot, which is normal. in our vision, this is supposed to be normal. Okay, imaging. Coming to the imaging. Finally, when you are done with the clinical and biochemical assessment, the next step is imaging. You don't have to directly rush to the imaging straight away. You have to go stepwise. So MRI of the brain and Sella region with multiplanar thin sections is of critical importance. You have to get a good MRI imaging or a CT imaging, because pituitary gland is a very small pea-sized gland, and if you take thick slices in imaging sections, then you may miss the diagnosis, you miss the you know this the actual anatomical area. So in this way, it provides axial, coronal, and sagittal sections of the Sella contents. You can understand how big the tumor is, to what extent is it spreading out. CT scan of the brain with Sella images may be sufficiently specific and can detect tumor calcifications. However, detail is inferior to that of MRI. So MRI is the first investigation of choice in case of imaging when you're suspecting a pituitary tumor. This image can tell you very clearly there is a big pituitary tumor here, which is pointed by yellow arrow. I hope you can all appreciate here. And you can also appreciate a fine grayish line in between, a semicircular line, which demarcates the anterior pituitary from the pituitary one. And this part over here, I hope you can see my white arrow as well. This is the optic chiasm, and this white thin line is the pituitary stalk, which has been quite distorted. Again, these are the coronal images, and you can see how this is the large pituitary tumor actually, which is rising from the Sella base, and these black eyes are the carotid arteries, and below these arteries are the cavernous sign. Okay, I can tell you here. You can see here very clearly, this is the pituitary gland. Tumor is invading beyond the cavernous sinus. Carotid arteries are appreciated in the normal cavernous sinus, which is blue. And this is the optic chiasm, which is being compressed or touched by the pituitary gland. This is where the visual field becomes affected. Now, what is the treatment for this for the pituitary tumors? Transfemoral microscopic surgery is the most frequent surgical approach nowadays for the resection of pituitary tumors. With larger lesions, a transfrontal approach may become necessary to decompress the visual pathway. Sometimes transfemoral surgery becomes insufficient to clear up or debulk or even cure the whole tumor tissue, and then you have to take a transfrontal approach. Then minimally invasive endoscopic surgery using a 4 millimeter endoscope through a nostril is a possibility in selective case. So these are fine advanced types of techniques to minimize the exposure of the tissues to open surgeries kind of ways. And through these minimal ways, you can achieve earlier healing and earlier recoveries. The main complication of transfemoral surgery is the cerebrospinal fluid leakage, which we call CSF rhinorrhea, and hypopituitarism sometimes, which is a common complication even after a transfrontal approach. But this can happen in transfemoral approaches as well. When you are trying to remove the main tumor or debulk the tumor, you may affect the normal pituitary gland. So I hope you got my point that the first line of treatment is surgical care. But if, for example, for any reason, and there are several indications and contraindications for surgery, the patient may need medical treatment. Then for acromegaly, there are somatostatin analogs, which is called octreotide, lanreotide, presidiotide, and so on. They can be helpful in the treatment of residual tumors post-operatively, as judged by the increased growth hormone level on OGDT, growth hormone suppression, and imaging. So you have to, reassess the patient after surgery. If they continue to produce these hormones, then that means they're not adequately cured. Some tissue is still lying there, and then you have to give medical treatment. Cabergoline, which is a kind of an alkaloid, then it has also been shown to decrease the IGF-1 levels, In particular, they act on the dopamine receptors, and they are particularly favorable for the treatment of prolactinomas. So, sometimes, as I told you earlier, some growth hormone secreting tumor can be co-secreting prolactin as well. So, they are particularly useful for treatment of those types of tumors. For Cushing's disease, we have ketoconazole, aminoglutamide, and mitotin. These are all adrenal steroid synthesis inhibitors. So you have a very long metabolic chain of steroid synthesis going on in the adrenal cortex, right from the start of the cholesterol entering into the mitochondria. And there are so many enzymes over there which are, for example, 3-beta hydroxy dehydrogenase, 720 alpha hydroxylase, and so on, 21 hydroxy alpha hydroxylase, and so on. So these are all enzymes which can be inhibited at several steps. In this way, cortisol production can be inhibited through these various drugs. Then finally, if the patient is not responding to medical treatment, or if there are no medical treatment options available, or if some patient has not undergone surgical treatment from the right step, so there are several ifs and buts in the management of these cases, then radiotherapy is a third line treatment option. It is an alternative to surgery and to treat residual tumors, actually. It required 1 to 2 years to show its effect of response, that is normalizing growth hormone, IGF level 1 levels in case of acromegaly, and cortisol suppression in case of Cushing's disease. So these are all management issues which we discuss when we come to specialized fields and far advanced expertise, and we have multidisciplinary teams in our city as well, fortunately, to deal with such things. We have endocrine society where these matters are discussed. So you should know that there are advancements in endocrinology going on in the country. Just to give you a brief idea that, okay, radiotherapy is an alternative treatment available, but be careful and be thoughtful that for radiotherapy to get its effect, to get cure, there is a long period you have to wait for. So for that long period, you have to treat the patient under medical coverage as well. Now, what are the different types of radiotherapy? We have conventional irradiation, and then there are gamma knife surgeries, gamma knife radio or robotic surgeries you might have heard of. And one of them is a cyber knife, which is, again, I should tell you all as an information that there is a cyber knife surgical treatment, cyber knife radiotherapy treatment available in our city. It is available in Jinnah Postgraduate Medical Center, JPMC. And it is one of the only South Asian center which is providing free of cost cyber knife treatment to its people. Remember this. This is the only free of cost. And I should tell you, one cyber knife treatment counts for thousands of thousands. I mean, 30 to 40,000 was the initial cost I was told about, but I'm not sure what's happening now. So this treatment is being provided free of cost because of several NGOs and foundations working in support of it. So people are coming from far-flung areas, from out of country as well, for such type of treatments in our city. Now let's begin with hypopituitarism. And hypopituitarism is a totally opposite kind of a condition I have discussed so far. Failure of one or more pituitary hormones to be produced or secreted from the anterior or posterior pituitary, or failure can be the result of any step in the production, in the stimulation, in the secretion, or its regulation. These all steps leads to hypopituitarism of that particular hormone. So there are several hormones being produced by the pituitary gland. One has to understand these feedbacks and steps of feedbacks and positive feedback, negative feedback, and how the one hormone is affecting the other gland. So one has to understand these types. This is step of lineage of hormones. Okay, CNS inputs, which can be several things: age, maturity, puberty, timings, growth, stress, trauma, whatever. It affects hypothalamus. This is the tier 1. hormone level. From here, hypothalamic hormones affect pituitary gland, which are tier 2, which is a tier 2 level. From there, pituitary hormones affect the target gland, which is a tier 3 hormonal level. So these are the various hormones produced by the pituitary gland, and their deficiency symptoms or signs are, for example, if I talk to you about growth hormone, it can lead to dwarfism, lethargy, premature aging. ACTH leads to Addison's disease. TSH leads to decrease in basal metabolic rate, heart rate, cardiac output, low blood pressure, weight loss, cretinism. Then prolactin, failure of prolactin secretion leads to failure of lactation in breastfeeding mothers. And absence of FSH and LH can result in late puberty, infertility, amenorrhea, and impotence in males. Oxytocin leads to prolonged labor, diminished milk production after the delivery, and antidiuretic hormone. Deficiency of antidiuretic hormone can lead to diabetes insipidus, dilute, and increase urine output. So there can be congenital and acquired causes of hypopituitarism. Among the congenital causes, there are several causes like developmental or structural, pituitary dysplasia or aplasia, encephalocele. So conditions other than the pituitary or Sella can also affect pituitary gland because of their compressive effects or anatomical distortion, which results in deficiency or hypopituitarism. There can be a congenital empty Sella, means the pituitary gland is not there, or it is lying in the ectopic position, or it is very much compressed. As a result, it is not able to produce any hormone. Perinatal insults like traumatic delivery, asphyxia leading to brain hypoxia affecting all brain tissues. Interrupted pituitary stalk interruption syndrome. It also leads to delayed puberty, short stature, and so on. Absent or ectopic neurohypophysis, as I told you, there can be ectopically placed neurohypophysis. Neurohypophysis is the pituitary gland, okay, and adenohypophysis is the anterior pituitary gland. Then congenital hypothalamic disorders like septo-optic dysplasia, Prader Willi syndrome, Kallman syndrome, Laurent-Moon-Bartle syndrome, Lawrence-Moore-Beadle syndrome. And I'll discuss briefly each one of them in the coming slides. So there are various acquired causes of hypopituitarism like neoplastic and vascular. Among the neoplastic ones are the pituitary adenoma itself, which can be non-functioning. Paracellular masses like germinoma, glioma, ependymoma. Paracellular means surrounding the cella turcica, and they are not inside the cella. Craniopharyngioma, Rathke's cyst. Secondary tumors like metastasis, lymphoma, leukemia, meningioma. And then vascular causes like pituitary apoplexy, Sheehan syndrome, sickle cell disease, and arteritis. There can be traumatic causes like injury, surgical resection, radiation damage. There can be inflammatory causes like lymphocytic and granulomatous hypophysitis. Infiltrative disorders like hemochromatosis, sarcoidosis, amyloidosis, histiocytosis, and infections again are like histoplasmosis, fungal histoplasmosis, toxoplasmas, tuberculosis, and pneumocystis carinii. So just to give you a brief description of septo-optic dysplasia, I'm telling this in a bit detail because when you go into the pediatrics, any of you might get interest in pediatric endocrinology, you may come across these cases quite often. So hypothalamic dysfunction and hypopituitarism results from dysgenesis of the septum pellucidum or corpus callosum in the brain. Okay, the midline defect, you can say, and if you can well appreciate the features, clinical or facial features of the patient over here. Affected children can actually have mutation in the HESX gene, and these children exhibit variable combination of cleft palate, syndactyly, ear deformities, optic atrophy, micropenis, anosmia. So you can see there are midline defects here, right from the brain, pituitary, nasal bridge distorted. I mean, it is suppressed over here. There can be cleft palate and so on. Pituitary dysfunction leads to growth hormone deficiency in short stature. Occasionally, there is thyroid deficiency as well, and as well as diabetes insipidus. Other syndrome to talk about is the Prader-Willi syndrome. It results from deletion of paternal copy of SNRPN and nectin gene. And the clinical features are usually hypogonadotrophic hypogonadism, hyperphagia, obesity, muscle hypotonia, mental retardation, and finally type 2 diabetes. So children often grow into adults, but they are hypogonad and obese, and they suffer several complications related to this kind of obesity. You can imagine patient can have diabetes, can have hypertension, can actually have respiratory problems, obstructive sleep apnea, and respiratory failure. So they become, in that case, they become tend to have high mortality. Then there is another syndrome called Kallman Syndrome, which is a type of a hypogonadotrophic hypogonadism, part of the hypopituitarism spectrum. Defective hypothalamic gonadotropin releasing hormone synthesis. So it comes all the way from the hypothalamus rather than a pituitary gland itself. This is associated with anosmia or hyposmia due to olfactory bulb agenesis or hypoplasia. And it's very difficult to identify this on clinical examination and brain imaging. So unless you have a clear family history or you have genetics in your hand, you may not be sure this is really Kallman syndrome. But of course, there are varieties of normal sense. I mean, anosmia means no sense of smell, and hyposmia is the decreased sense of smell. But patients can actually present with normosmia, that is the normal sense of smell. So, although their olfactory bulb agenesis may not be complete in that cases. So they can have associated color blindness, optic atrophy, nerve deafness, cleft palate, renal abnormalities, and cryptorchidisms along. So you have to look into these other features as well. The gonadotropin releasing hormone deficiency prevents progression through puberty. So patient often comes to you with delayed puberty symptoms. Females can come with primary amenorrhea. Males can come with, delayed puberty, like no hair appearing on the face, on the bearded areas, in the armpits, or in the pubic areas, or no erections, small size penis, and small testicles. And hormonally, it is characterized by low FSH and LH, similarly low concentration of sex steroids. Another syndrome is the Lawrence-Moon-Bardet-Biedl syndrome. This is a rare autosomal recessive disorder. Clinical features characterized by retinal degeneration. You often get to have retinitis pigmentosa on fundoscopy. A patient is unable to see, vision is affected, especially the nighttime vision is affected. There is a tunnel vision. A renal abnormality is there, renal defects can be there, mental retardation, and obesity. Other features can be hexadactyly, brachydactyly, and syndactyly. So there can be a lot of defects in the fingers or fingers or toes. You can see there can be increased number of fingers, there can be small fingers, there can be fingers which are joined together. Central diabetes insipidus may or may not be associated. GnRH deficiency occurs in 75% of males and half of affected females. Retinal degeneration begins in early childhood, so most patients are blind by the age of 30 years. Now coming to pituitary apoplexy, which is also one of the cause of hypopituitarism. Pituitary apoplexy is characterized by spontaneous hemorrhage into the pituitary adenoma or tumor and is considered as a neurosurgical emergency. Patient present variable onset of severe headache, nausea, vomiting, meningismus, vertigo, visual defects, altered consciousness, and symptoms may actually occur immediately or may develop over 1 to 2 days. So you have to be very careful with someone coming with a headache or with severe headache or visual defects. It should, immediately click in your mind that, okay, this patient may have some brain hemorrhage or at least something affecting his vision, so I should get the imaging done immediately. And in such cases, CT scan of the person comes prior to MRI. Why? Because you have to detect blood if there is a hemorrhage there, which is more devastating and dangerous than anything else, because it will continue to bleed, it will continue to affect the brain structures and compress the brain structures and affect the functionality. This is normal imaging of the pituitary. Please appreciate everyone, because once you know normal, then only you will be able to know abnormal. So this is a pituitary gland here, which is a pea-sized gland. You can see a bright signal here. Sorry. This is a bright spot here. This is the normal posterior pituitary gland, okay? And here is the pituitary stalk, and this is the optic chiasm. Again, this is a coronal section. You can appreciate a normal pituitary gland here in the Sella turcica. And this is pituitary stalk and pituitary optic chiasm. Now, this is the picture of pituitary apoplexy on MRI. Look how big the pituitary gland has become. Why? Because of the blood in it. And this is a sagittal section showing large black shadow, which is a blood. And these are different images. Again, here, if you can see, this is a coronal section again, which is showing a heterogeneous mass located in the Sella, because blood may be resolving. So there are cysts, variable cysts and calcifications going on because hemorrhage may be resolving. So this tumor has actually enlarged because of the blood inside it. Then there is a condition which is called Sheehan syndrome, and infarction of the pituitary after substantial blood loss, especially during childbirth or labor. You can appreciate the bleeding here, the infarcted area here, because after the blood loss, the blood flow to various tissues of the body are affected, and so is the pituitary gland, because it is very delicate tissue, delicate organ, and it has a very delicate kind of blood supply. And if that blood supply is interrupted or decreased for any reason, for example, during childbirth, excessive postpartum hemorrhage occurs, then infarction of the gland will take place. And this infarction will result in hypopituitarism. Incidence is 3.6, but I should tell you, I have done, I have published my own research article on hypopituitarism, and I have found Sheehan syndrome to be prevalent somewhere between 10 to 15% in our population, which is quite high. So, I mean, it can be because of various gynecological practices, obstetrical practices, patients coming late in the tertiary care setup or whatsoever. But the incidence is definitely different in our setup. So no correlation between severity of hemorrhage and symptoms. And you cannot assess if the patient really has this problem. So you have to, so again, you have to dig out a thorough history of the past obstetrics and the patient had, and what was the past, how the patient was delivered. Patient had delivered. Was there any excessive bleeding after the delivery? The patient needed blood transfusions. How many blood transfusions? Was the patient able to breastfeed her baby after the delivery? Because if there is no hormone coming out of the pituitary gland because of pituitary infarction, then how would there would be no prolactin, there would be no oxytocin to give milk to the baby. So this is very tricky history, which only someone who knows that there can be a possibility of Sheehan's or a hypopituitarism in such lady, then only you'll be able to answer questions such way. And patient can also present and complain of amenorrhea if it has been there for several years. For example, I have many of my patients who are Sheehan syndrome cases, and they are not having menses for the last 10 to 15 years, and they have to take pills to continue to have normal menstrual cycles. Severity is recognized months to years after postpartum, as I've told you, and there can be lethargy, anorexia, weight loss, unable to breastfeed, amenorrhea, and so on. Then I think this is the last syndrome I'm talking to you about today with regard to pituitary gland. Empty cellar syndrome is also something common now and easily recognized if you have that in your mind. An empty cellar can develop as a consequence of a primary congenital defect in the diaphragm ocelli, or it can be damage to the cellar diaphragm can lead to arachnoid herniation into the cellar. And when the arachnoid herniates into the cellar, it brings CSF fluid along with it. As a result, there is compression of the pituitary gland, and you find that there is an empty cellar and the pituitary gland is lying compressed on the floor with almost no function. So patient can have hypopituitarism. Usually they have normal function initially, and implying that the surrounding rim of pituitary is still fully functional, but hypopituitarism may eventually develop insidiously. Etiology can be congenital, as I told you, but it can be iatrogenic sometimes, and there can be primary hypophysitis leading to it, or a pituitary adenoma with silent infarction or trauma or surgery, radiation. So any condition can actually lead to empty cellar syndrome. Any condition affecting the cellar floor, cellar anatomy can actually lead to empty cellar syndrome. Sometimes you come across clinical situations in your practice in endocrinology there are middle to elderly age group females admitted in the ward for some infection, sepsis, or whatever other medical reason, and sometimes they're not able to have a normal blood pressure. Their blood pressure is going low, and then you as an endocrinologist is called to assess if there is any cortisol issue or Addison disease going on. And when you start assessing, you may have you may take history, and then patient may give you a history of, sometimes that, okay, I had an earlier or premature menopause, and then you go on to assess whether patient may have some pituitary defect or not, and you start pituitary hormone function testing, and you get a low FSH and LH. So in a patient who had a menopause, you expect to have a high FSH and LH because the ovaries getting into degeneration, natural degeneration. But in case of an empty cell with hypopituitarism, you may actually find low FSH and LH in a menopausal woman. And that may strike you, okay, this patient may have some abnormality in the pituitary gland, so let's go for an MRI. And then you find an empty cell. There can be a past history of Sheehan syndrome in such cases as well. So this is a diagrammatic, demonstration of what I told you about how an empty cella is formed. As you can appreciate here, this is a normal pituitary gland, a normal anterior pituitary, posterior pituitary with the pituitary stalk. This is the CSF in the front and behind. And if there is a defect here, as you can see, there is a defect in this blue line is the dura mater, which is which forms the diaphragma celli on above the sella turcica. This, if there is a defect here, the arachnoid matter is herniating into the sella turcica, bringing CSF along with it. As a result, the anterior pituitary, which was green and big here, has become a rim-like tissue over here. So this is compressed, but it may be fully functional still. With passage of time, it may go on to develop hypopituitarism. So that's all for today's lecture. I hope you're not sleeping, and if so, then thank you very much. I would appreciate any question if you have. Thank you. Should I stop sharing the slide? Slide share बंद कर दूं? लेक्चर तो खत्म हो गया है, बंद कर दूं फिर?
हेलो, अस्सलाम वालेकुम जी मैडम, एंड करेंगे?
हाँ, एंड कर दें।
क्वेश्चन आंसर नहीं करेंगे या नहीं, बस एंड करो?
मुझे नहीं पता, अगर क्वेश्चन आंसर करना है किसी को।
क्वेश्चन आंसर है ना, देखिए आप देखें मोड में जाके ना एक ऑप्शन है चैटिंग का, वो ऑन कर ले। स्टूडेंट को आप बोलेंगे ना तो ये
अच्छा, हाँ,
भेजेंगे तो आंसर दे देंगे।
ओके। Does anyone have any question? Oh, sorry, I can't hear anyone.
चलो ठीक है, ओके, अल्लाह हाफिज़, टेक केयर।
Is it okay?
जी ओके।